Hello guys, I hope you're doing good. This is Dr. T. Welcome to today's chat. Once again, thank you guys for subscribing. Let's hit that notification bell, let's like, let's share. That's the only way we can grow the channel, and when you do that, you'll be helping me to reach more students, more interns, and other people who might find the content interesting. Okay guys, I want to introduce you today to a new feature. In this feature, I'm gonna call it a patient I saw. So what I'm gonna do in this feature, when I encounter a patient that is worth discussing, specifically that patient, and talk around the management of that patient, I will do that. So it's gonna be a patient that is interesting, and our discussion is gonna sort of like start from there and discuss around. So it will be something that I've seen, and I'll tell you what I did with that particular patient. For ethical reasons, I will not say the name of the patient. I will try to minimize any information to protect the patient and all of that. So let's jump into it. So it's gonna be a patient that I saw. So I was on call yesterday, Saturday, for 24 hours in A&E. So the patient that we saw so many patients there. We had a rough call. It was like a very, very busy call. It was month end. You know, the stabbing, you know, the car accidents, you know, the people falling, slipping and falling, like they would trip and fall, things like that. So, but this is one guy that I want us to talk about. 32-year-old male comes in with a history of having been stabbed on the left anterior shoulder. So when I came to him, so I was called to come and assess him and see what's happening. So I found him sitting on the chair. He was comfortable on the chair, but I could see that he has been bleeding because his t-shirt was just like full of blood. His BP was 105/69 with a pulse of 91. So judging by the pulse, I was comfortable that okay, we don't have a patient that is in shock at this point. Remember, the first vital sign that changes in shock is pulse. So you want to pick that pulse as it goes up, because by the time you've got hypotension, a low blood pressure, like it's kind of too late. So yeah. So as he was sitting there, so he had a stab wound that was just here, about 2 centimeters, 2 centimeter stab wound that was there. As you leave the upper chest into the arm, that's where the stab wound was. So he came in, he was strapped. So when I opened up, removed the strapping, I found that he was having a huge hematoma there, a huge mess. Let me put it that way. He had a huge mess there. So I ran my finger in through that wound. I found that this was the hematoma. I couldn't get to the bottom of the hematoma. That's how big it was. The hematoma was not expanding. It was just there, and he wasn't actively bleeding at that point. And I thought to myself, because I was assessing him to see what do I need to do. So as I was assessing him, I realized that there was this hematoma that was there, and if I try and dislodge it, he might start to bleed, and I don't want that. So I checked for his radial pulse here, which I found it to be very faint. And on the others, because it was very faint like that, remember, one of the things that can be so confusing is, alcohol. Because yes, this patient was intoxicated. Alcohol is a very good vasodilator. So a small cut will make a patient to bleed because of that. And you will think that they are bleeding a lot because of the severity or how deep the step wound is or whatever. And yet it's not that. It's just that they are under the influence of alcohol, and alcohol is a vasodilator. But at the same time, you don't want to say to someone, okay, now they're just bleeding because of alcohol, go and assess the wound. But if the way they've been bleeding is not proportionate to the size of the wound, then you might say, okay, no, but you want to assess that. So, and also someone who has been drinking and they're not wearing anything, because the shirt was like there with blood, I was not wearing it, they can also, and because of the cold, they will constrict peripherally on the legs and the hands. That will cause a discrepancy in your pulse on its own. And also if they get into shock, when you get into shock, you vasoconstrict as well. And because the body wants to channel blood to the vital organs, so you will have a decreased pulse. But what is important, compare with the other side. So that's what I did. I compared with the radial pulse. On the right side, it was strong. It was strong. It was the volume was full, but this one, there was discrepancy. It was very faint. So okay. So what I did is, because the patient, I was not under pressure to try and suture because he was very stable. He was not bleeding. And I thought to myself, if I try and suture this, I might need to go deep and try to catch a deep lying artery or a bleed. But the problem is that area, I could catch the main artery, like the brachial artery, and ligate it first. Number two, I could catch the brachial plexus and ligate that as well. It was very risky. So what I did is I put this thing back. I put a gauze, because they didn't use gauze and a creepanish. So I put gauze and a creepanish, and I made a tight strap around that to make sure that it's compressed. And then we had already put an IV line on the right at that time, on the right side with Ringer's lactate. So I went to call the surgeons. So I presented this patient as a query. Why did I present this patient to the vascular surgeon? Number one, this is someone who's got, so the main thing was the faint pulse. Faint pulse. Number two, that hematoma was massive. Massive hematoma. Number three was the location was worrying. A lot happens there at that junction. And that was the location. What else was worrying? The location, the size of the hematoma. So I presented this patient as a query, a vascular injury, mainly the left brachial artery. The surgeon accepted the patient. Then the patient went. He was stable, called the ambulance, and So this brings us to vascular injuries. I've just called, before I did this video, I've just called the surgeon now that I referred to. He's a very nice guy that I used to, when I was doing surgery, I've worked with him, so I know how he is. So I've just called him now. He said they did a CT angio, and luckily there was no vascular injury, so the patient is fine. So shout out to Dr. Malongwe. Thanks, doc. So he didn't have a vascular injury, this guy. So let's talk about vascular injury, and I will tell you why I sent that patient. Vascular injury. So when it comes to vascular injury, okay, we know that the mechanism of injury can be penetrative or blunt, and I don't know of any other. Those are the two that I know. So vascular injury, we've got what they call hard signs of vascular injury, and then the soft signs. So guys, as an intern and as a final year medical student and medical officer going up, it's not so exciting to find someone who's got a wound and then you suture them, and then it makes you feel like a doctor, and because that's how we used to feel in the junior years. When you suture someone, it gives you that confidence that yeah, you are a doctor, you're on the right path and stuff. But when someone has been stabbed, what is exciting as an intern is to diagnose vascular injury and appropriately manage it, or to have it at the back of your mind as you assess the patient, and not just be excited about the wound, the wound. So hard signs. So when you've got hard signs, literature says that you've got about 90 to 100%. Some even say 100% actually. There's some that says more than 90. So when you've got a hard sign, not hard signs, when you've got a hard sign, you've got about 90 to 100% chances that you might be having a vascular injury. And what are those signs? One, a hematoma that is expanding. A hematoma that is pulsatile. That's number one. Number two, so it's a hematoma that is expanding or a pulsatile hematoma. So you don't have to have all of those. So what's an expanding hematoma? An expanding hematoma is a hematoma, you see it now, it's this big, but when you come back a few minutes later, it has increased dramatically in size. That's expanding. And a pulsatile hematoma is like whenever there's a heartbeat, you see it sort of like moving like that. You'll hear it's like the beat will be like boom, and then you'll just hear it move. You'll just see it moving boom, boom, boom. That's a pulsatile. So what I'm trying to make you to understand is that you don't palpate for it. So you can just see that it's doing that every time there's a beat. It's just doing that. That's a pulsatile hematoma. Number two, it's obvious artery injury. So if you see that there's an artery that is torn, that is cut, that's a hard sign. And also if you see that there's an artery that is like gushing, it's like you've opened a tap water, and it's bright red blood coming out, that's a hard sign. And also if it's spatting, every time there's a heartbeat, you just hear blood like gushing out, like spatting like that. So you know there's an obvious artery injury. You can see it, even if there's no hematoma, but you can see it. Also, if there is a trail or a bruit, so a bruit will be like, we put a stethoscope and then you hear sound like like that. Number three, when you palpate and then you can feel it's like you will feel like you will pick up vibrations with your fingers or with your hand. That's a trill. And then number four is signs of ischemia. You don't want to get here. This is where they talk about the 5 P's. The 5 P's, which is pain out of proportion. Pain out of proportion is like you've got a stab wound here, but the pain that the patient is complaining about, you don't like, it's way disproportionate to the wound. You know, when you've got someone who's a stab abdomen, you can sort of like have an idea how much in pain are they gonna be compared to someone who's a dog bite, or someone who was maybe kicked by a horse. So it also depends on the location, the mechanism of injury, or someone who was slapped. So that you can, so now if someone says I was slapped, and then the pain that they are in, I'm just making an example. So that's how it is. And also, if you give someone painkillers, like give someone like strong, you give them opioids, for instance, but the pain is still, they're still complaining of pain, then that's pain out of proportion. And then there is paresthesia, needle-like pricking pains with some numbness. And then there's pallor, and then there's the worst is paralysis, and the other one is pulselessness. So those are the 5 P's. When you've got these, it tells you that now that arterial injury is causing ischemia, and also there's also potential damage to the nerves that run with that artery. You know, most of the times a nerve runs with an artery and a vein in most body parts. So you don't want, so those are the hard signs. So if you see one of these, you can refer that patient as someone who's got hard signs of a vascular injury. What are the soft signs? They say soft signs about 35%, that when you've got a soft sign that you will actually do an angio, and then there is a vascular injury. So what are those? You know, this depends on what article you read, who wrote the article, which university or which research, and all of those things. But what's important is you must know about hard signs and soft signs, and so that when you have a patient, you can save a limb or save a life. Okay, so the soft signs would be a hematoma, but not expanding or pulsatile. Hematoma. My patient had a hematoma. It was not expanding. It was not it was not pulsatile. Number 2, what is number 2? Location. So if someone has got bleeding in an anatomical area where you expect an artery, you know that there's an artery, anatomical, there's an artery that runs there, you can sort of like say, okay, soft sign. And then if someone has got a history, like there's a history that they bled a lot at the scene, then that's a soft sign. Number 4, if someone has got hypotension that cannot be explained, hypotension that cannot be explained, because if you explore that hypotension, you might find that actually this patient has a vascular injury, let's say abdominal, they're in MVA, or in the you do a fast, and then you pick up, use that ultrasound, then you check, oh, they've got collection of blood in the abdomen, then likely maybe they've got an intra-abdominal vascular injury. So my patient, the reason why I refer that patient, you know, when I've got soft signs, I will refer that patient. I'm not going to wait for hard signs. That's what I've just decided to do. If I've got soft signs, I will still refer the patient. So my patient had a hematoma, not an expanding or a pulsatile. Number 2, the location, I was worried about that location. And also, this is a plus minus. Like he had bled, I could see that his shirt was blood soaked. But another thing, we've got this thing of alcohol that is a vasodilator that just makes people to bleed a lot, even from small cuts and all of that. So that's that, guys. So vascular injuries are very important, because a patient who's got a vascular injury, even if you can put up a limb, a POP or a back slap and pick up a fracture, but if you didn't pick up the vascular injury, then all your work just goes down the drain. As we are still learning as young doctors, like I normally say that, you know, we don't have experience as interns. Even as ComServes, we don't have experience. But what is gonna help us is knowledge, is reading. You know, when your knowledge is, I don't want to say good enough, but when you are knowledgeable about a lot of things, you will compensate for your lack of experience. And then yes, there are things that will just take you out, but then majority of the cases you will manage because of what you know, not because of what you have done, because you don't have experience. So knowledge becomes our only backup. And another thing that I've always told myself is that, actually it's an advice that I got, that when whatever department you go to, you rotate to, you must work as if you wanna be a specialist in that department, and you leave them confused. You leave your seniors confused, thinking that you wanna specialize in their department, and yet you know where you wanna specialize. Be it PEDS, you put the same amount of work, you put the same energy, be it PEDS, be it obs and gynae. You know, there are people that think that I wanna do obs and gynae. There are people that think that I want to do surgery. There are people that think that I want to do family medicine. There are people who think that I will come and do internal medicine. But not that I've told them anything, but because they have seen how wherever I am, when I'm in psych, I will become like a psychiatrist. When I'm in anesthesia, you will think that I want to do anesthesia. So that's what we should, because we never know where life is going to put you. I know there are interns that have already specialized in their mind. It's so concerning when you have an intern who has already specialized in their mind. They know that when they go, so they know that, okay, I want to do obstetrics. So they work hard when they are in obstetrics. They push when they are in obstetrics. And then when they are in other departments, they're just like relaxed, and that does not help them, because I mean, you don't know where life is gonna put you. You don't know where life is gonna put you. So push yourself in. If you don't like, I don't like everything. I don't like everything. There are things that I like, but because I want to put myself at an advantage, so that if you push me to PEDS for whatever reasons, I just become like a pediatrician. If you put me in maternity, I'll just become like an obs and gynae specialist. So not really specialist, but I'll be comfortable as if I'm sure you get what I'm trying to say. So guys, don't specialize before you specialize. Yes, you might love psych with all you have, but don't specialize before you specialize. Don't put the same energy that you would put in psych when you go to obstetrics. Put the same energy that you would put in and leave them confused, thinking that you're going to come in and work in that department. Okay, so another thing that I want to briefly talk about, it's not today's topic though that I wanted to. I said that guy had a stab wound. I know you can go to any A&E department in South Africa. You will find someone who has been stabbed, and then the doctor there has written that the patient had a laceration. I also write it sometimes, but it's not that we are correct. It's not that we're not necessarily wrong, but if we want to be very right, then we are wrong. If you want to be very right about this thing, then we are wrong. Why? A laceration, a laceration is a wound that has been caused or inflicted by a blunt object. And that blunt object leaves a wound that has got irregular edges, like ragged edges, because it's blunt. So when you take a metal rod or a wooden rod and then you hit someone, the energy that is in that metal rod is going to be transferred to the tissues. Then the tissues will open up. It's going to split the tissues, and then they will be torn. It's going to leave like a irregular edges. That's a laceration. So by definition, it's caused by a blunt object. So we cannot say a stab wound is a laceration because it's caused by a sharp object. And then when you talk about that's a laceration, But now when you talk about a stab, when you say someone has got a stab wound, you have not committed, you have not said it's a knife, it's a screwdriver, it's a razor, it's whatever, it's a bush knife or whatever. You just say, you just know that because of the wound, the edges, they are sharp. Because they are sharp, it's sharp edges. And remember, they will tell you that a stab wound is deeper or longer than its width. That's a stab wound. So, but what I want to talk about is that it has got smooth edges because the whatever that caused it has got is sharp. So the energy that you use to stab is minimal compared to someone who wants to cause a wound using a blunt object. There's a lot of energy in for you to split the skin from a blunt object. It means you must have used a lot of force. Other wounds are your abrasion. An abrasion is like exfoliation of the top layer of the skin, like it gets removed, and then you often find there is a whitish base there, which is the dermis. So that's an abrasion. But then when you talk of a bruise, when someone has got a bruise, it means that whatever that hit them managed to damage the underlying vessels. Now there's just blood that has just seeped out of that out of the arteries. And normally these, when they are fresh, they look red, and then as they become old, they look grayish blue, and then some people call it something like a blue eye. So it's because now the blood that is there is deoxygenated, is old blood and all that, so it has lost its red color. I'm sure there are other wounds as well, but that's what I wanted to just speak about there. So our patient, because of the blood pressures were normal, we put an IV line on the right side, was fairly stable, but I was just concerned about the soft signs. So he had about 3 soft signs. You see, 3 soft signs for me were a lot. So I could have easily said, let's observe this patient and examine maybe in 2 hours time, and then see how the pulses are gonna be. I could have done that, but I mean, our tertiary hospital is like 5 minutes walk from where I'm working now. So sending him was gonna save me 2 hours of having to come back because we were so busy and all of that. Probably if I was in a deep rural setting where it takes about 5 hours or 4 hours to get to a tertiary, I was gonna keep him, but I was gonna have that burden now of having to go back and examine the patient and all of that. And I mean, who knows, when you're tired, anything can happen. So guys, that's that. I hope you enjoy this feature, this new feature, a patient that I saw. Okay, bye.